Good morning and welcome to our UBC Learning Circle, Dismantling Colonial Structures in Public Health, the journey of two First Nations women with Eryn and Jorden. Today's conversation is presented in partnership with the Center for Excellence in Indigenous Health. We'd like to thank the First Nations Health Authority for generously funding the UBC Learning Circle and allowing us to have these conversations. Before we formally begin, I'd like to acknowledge with respect and gratitude that I'm joining you from the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh Nations. For those of you who don't know me, my name is Terrain Squawkin. I'm Syilx Okanagan on my mother's side and Hickory, Apache, and Belgian on my father's side. I will be the moderator for today's discussion, and working behind the scenes is Cynthia, our production coordinator, and Kira, our program assistant. They'll be in the background interacting with everyone in the chat. And finally, before we get into today's discussion, I'll provide a gentle heads up that the topics covered may be sensitive or emotionally triggering. So please make sure that you are looking after yourself, and if at any point in time you need to talk to an elder, friend, counselor, or family member, don't hesitate to do so. We have some prompts in the chat if you need additional support. Now I'll turn it over to our guests to introduce themselves.
Namaste, hello and welcome. It is so wonderful to be with you all on this day. My name is Eryn and I'm so honored to be here alongside my colleague and my best friend Jorden, and with the Center for Excellence in Indigenous Health that really was the launching pad for me in my career and has played such an important role in surrounding me with the network of Indigenous peers and mentors that I have today. So super excited to be here. I'll start off by introducing myself and then I'll pass it over to Jorden for her introduction. So I'm Cree. I'm a member of Saddle Lake Cree Nation in Treaty 6 territory from my father's side, and I am British and Irish settler from my mom's side. I live and I work on Lekwungen People's Territory in what's known as Victoria, BC. It's a beautiful day here and looking forward to getting outside at some point so I can feel the good medicines of these lands that keep me healthy and well every single day. And I recognize that me as an uninvited guest, this is me living off the richness and the stewardship of the first people of these lands and my responsibility to be good medicine on these lands as well. I work within the healthcare system in BC to eradicate Indigenous-specific racism and embed inherent Indigenous rights. Specifically, I work at the Provincial Health Services Authority Indigenous Health Team under the leadership of Joe Gallagher. So when I think about who I am, I think about the people in my life who have supported me and who have guided me and helped shape the path that I walk today. So now that you can see the pictures, the two pictures on the left show me and my twin sister, Mackenzie. And I recently learned that in Cree teachings as twins, we are one heart or one soul in two bodies, which really speaks to the relationship that we have. And in those pictures, we are with the two strong women who raised us, our mom and our grandma. And my mom, who not only raised twins and then later a little brother shown in the other picture on the left on her own, but also went through university and got 2 degrees to achieve the career that would support us. And she really modeled that we could do whatever we wanted to do and whatever we set our minds to in life, no matter the obstacles. I grew up without knowing my Cree family and my Cree community. And when I was in my early 20s, I started feeling more and more of a want and a need to connect with who I was and who I am as a First Nations and a Cree person. The bottom middle picture represents the Indigenous women that I've met along the way who have taught me so much about who I am, my responsibilities and accountabilities to myself, my community, and the peoples whose lands I reside on. So you'll see Jorden on the left in that picture. And on the right are my Cree ancestors who have come before me. The top is my great-great-great-grandfather, Chief Little Hunter, who was the last hereditary chief of his people prior to the Indian Act. And he signed Treaty 6 on behalf of his people and for those that would come after him, including myself. And below is my late grandma, Margot Quinn. And I know that my ancestors have paved the way for me to be strong and healthy and well today. And I hope to continue down this path so that the ones who come after me will be even stronger and healthier and connected to who they are as Cree people. So with that, I'll pass it over to you, Jorden, to introduce yourself.
Thanks, Eryn. Hi, everyone. I'm so excited to be here talking to you. I'm loving all the comments flooding in and everyone introducing where they're coming from. It's really cool. It's such a diverse group of people from all over BC and beyond. So my name is Jorden Hendry. I am Tsimshian and a member of the Lackawanna band from my mother's side. And I have settler, Irish, Scottish ancestry from my father's side. I'm so excited to be here speaking to you all today on the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh peoples. I have been a guest on these lands for about 8 years now. I grew up on the banks of the mighty Skeena River in Terrace, BC, on Tsimshian territory. But then I eventually made my way down south to go to school. And so currently I'm still in school. I am a PhD student in the School of Population and Public Health at the University of British Columbia. I also work with the Unlearning and Undoing Racism and White Supremacy project that is now currently based out of BC CDC. My work kind of focuses a bit on Indigenous public health, but also looking at the settler health systems and kind of working towards health system transformation. It's really exciting to be talking in the Learning Circle because I started when I came to Vancouver working with the Center for Excellence in Indigenous Health, and I worked with all of the different programs, the summer science program, 23-24, but I also worked as a program assistant for the Learning Circle. So if you were on the Learning Circle in 2018, I was the one getting you tea and coffee and making sure you're comfortable in our room. And so it's kind of come full circle that I get to come and talk to everyone on the Learning Circle. It's a huge honor to be here. So I'm going to tell you a bit more about myself and specifically my family members and the brilliant, strong women that really shaped who I am today. So you can see the top left photo is taken in 1950, and the small girl in the middle is my grandma Frances Therian, previously known as Frances Kelly. On the right of her is Loretta Kelly, her mother, and on the left, I don't know her name, but I was told that Loretta always had her friends over 24/7 helping raise my grandma because my great grandpa was a fisherman and he was out pretty often helping the family. And so below that photo is again my grandma many years later, helping prepare our fish for the summer and the season and looking a little annoyed probably because my sister and I are like running around her like crazy while she's trying to get her job done. The top right is a photo of my late Aunt Diane. I always include her in my presentations. She has really taught me to stand up for myself and what I believe in. And I think she's probably the toughest person I know to this day. The bottom right is a photo of my mother, Denise Hendry, and I. My mom is an Indigenous educator who works for the BC Teachers Federation. Growing up, she would sometimes take me to Vancouver and I'd get to sit in the back of her workshops and color and sometimes listen. And this photo here is actually when I had the opportunity to go and present at my mom's work for her and her colleagues. And so again, it was a full circle moment and I'll definitely cherish this photo forever. So I'm just gonna do some explanation of what we're here talking about today. So Eryn and I are going to be talking to you about our experiences as students in public health, what we saw, what we witnessed, and then how that led us into our careers of dismantling Indigenous-specific racism in the health system. And so we're going to dive into a deeper understanding of the way that racism and white supremacy show up in our health system and trickle into everyday care. It has really been instilled in me that the lens we do our work from will have an impact on the actions we take. And so I'm going to briefly share the lens in which we are coming to you from today. And so I think I can speak for both of us when I say we're on this collective journey of eradicating Indigenous-specific racism, but a significant step of that is recognizing the ways in which our current system was not built for First Nations people. Rather, it was built by and for white settlers. And something that I really try to remember when doing this work is that it's so possible for Indigenous people or people of color to hold beliefs, practices, values of whiteness. And that's because it's so seeped into our system because of colonization, and often it's all we've ever known. I also want to acknowledge before we really get started that knowledge really flows through us. This was a teaching I got from Elder Doris Fox, and she shares it with me all the time. all of the teachings I received over my lifetime have helped me with this work. And so the information that we're sharing today is not some brand new concept that we came up with, but rather it's a collective of teachings that we've received from all those in our network, all of our amazing mentors, all of our family, and we're distilling it and sharing it with you today. So it is our protocol to always recognize the inherent rights of First Nations that stretch to every inch of this province and beyond. Inherent rights are rooted in connection to lands and waters and have never been ceded or surrendered. Inherent rights are also upheld in international, national, and provincial law. And for me, always sharing this slide is a really good reminder to carry out all of the work that we do from an Indigenous rights-based lens. I'll pass it over to you, Eryn, to do some level setting about public health.
Yeah, thank you so much, Jorden, for grounding us in the rights of First Nations people and Indigenous people, and specifically recognizing that the lands that we come to on BC are on BC First Nations territory. So we want to just provide some background to what is public health, just to make sure that we are all on the same page here. So much of our health is impacted by the social and environmental conditions where we are born, where we grow, where we live and age and work and play. And these are called the social determinants of health, and they include income, social support networks, education, culture, self-determination. And while the healthcare system is a downstream approach to treating people who are sick, public health is an upstream approach that aims to promote health and wellness and to prevent people from getting sick in the first place. So it includes vaccination programs, ensuring people have access to safe water and safe foods, encouraging healthy behaviors, and creating healthy environments. Epidemiology is one part of public health that monitors risk factors, disease trends throughout a population, and seeks to identify the risk factors or the exposures that result in disease. And so we wanted to talk a little bit about what led us into the career of public health, and I'll pass it over to Jorden to talk about her journey to public health.
Thanks, Eryn. So to start, this photo is of Eryn and I at our graduation from our Masters of Public Health degrees, which feels like forever ago now, but it was honestly such a beautiful day. So my start into public health was really through my work with the Center for Excellence in Indigenous Health. I kind of got to see what public health meant from taking part in these different programs. And I felt like I had this desire to acquire more knowledge and tools in this field. So I started my master's, and I quickly noticed a disconnect between the narratives that are very prevalent in public health and the stories of my own family. The narrative in public health is saturated with negative statistics for Indigenous people, painting this picture of despair. And that really contrasted the vibrant, thriving communities I knew. And so I felt a bit unsettled because public health didn't really reflect the reality of my experience with my family, who are First Nations people who are flourishing in many aspects of their life. And so I persisted in the field, but I realized that I needed to be the one to bring in a strength-based perspective. I needed to be the one to show people the beautiful worldview of Indigenous peoples. And I'm not going to lie, engaging in Indigenous-focused work within the framework of a Western public health system definitely proved to be challenging, because it's hard to go against the grain. But something that really helped me get through my time and was honestly a big turning point is when I met another strong Indigenous woman who really shared the same vision and aspirations for this work, and that person was Eryn. And it became so clear to me that nobody should be doing this work alone. Nobody should be challenging a system, calling out instances of racism, disrupting deep-rooted colonialism on their own. And so the way I was able to survive in the system was finding someone else who cared, so we could lean on each other and hold each other up. And that really grew into a wider network of people. And so eventually we had this family of Indigenous health leaders who are just constantly leaning on each other. We're holding each other up, and it's become this beautiful, thriving place.
Yeah, I completely agree. Our relationship was so instrumental in supporting each other and then later on growing into a larger network of people who we surround ourselves by. Jorden and I instantly flocked together as two of the only Indigenous students in our cohort. And not only were we in the same cohort, the same classes, but we were both working at the same place, and that was the Center for Excellence in Indigenous Health. And I remember at the time our friendship seemed quite serendipitous. But as our network expanded and we met more and more Indigenous people who have gone through programs either at the School of Population and Public Health at UBC, beyond, we noticed that this seems to happen a lot, that we as Indigenous people, we find each other and we wrap ourselves in love and support because that Indigenous connection is what helps us thrive. And through this friendship and this connection really reinforces one of the guiding principles that we go by in our work, and that is that no one should have to do this work alone. So I wanted to take a step back and talk about my journey into public health and what interested me in this area. So before my public health degree, I started with a bachelor's of science. And I knew broadly that my interests were in health, but I wasn't quite sure. And I was taking medical genetics and cancer biology and immunology, and I could tell you the exact genes, the pathways, the proteins that led to the development of a cancer, for example. But what I was always missing was that broader social lens of what happens in someone's life that triggers that pathway to happen in the first place. And not only that, but why does that pathway get triggered in some people more often than others? I knew what chemotherapy, radiation, what various treatments would do down to the cellular level. But why are some people in the population benefiting less from the same treatment that is saving lives? Why are Indigenous people less likely to be diagnosed with a cancer and are more likely to experience poor survival outcomes? And at the time, I would have told you all gung-ho and a little naive that, well, we need to promote awareness of cancer care and screening to make it more accessible. And this led to my decision to pursue public health to make a difference in the health and wellness of Indigenous people through upstream measures. But what I noticed was a lack of conversations or inappropriate conversations around the why when it came to poor health outcomes in Indigenous peoples compared to the general population. I knew that why, through my own lived experience as an Indigenous person, but I didn't have the tools to talk about it in a good way that highlights the exact problem at hand. And I began to realize through my own work networks that Indigenous people did not face poor cancer survival outcomes because of a low awareness, but that they experience poor survival outcomes because of the socioeconomic marginalization that creates the conditions for the development of cancer, and because of Western healthcare services that are unsafe and entrenched with racism. It was nothing to do with what Indigenous people were lacking and everything to do with the system. And so that's what I do, and what Jorden and I do in our work now is focusing on that system. So we want to highlight some specific observations now that we had made throughout our journeys in public health and how they relate to colonialism. So in True Reconciliation, Jody Wilson-Raybould talks about the connection between our worldview and the world that we create. Our worldview shapes the society that we build, our laws, our institutions, our systems of government, including our social and health systems. And the settler state in Canada was predominantly shaped by European worldviews. For the purpose of colonization, Indigenous peoples have been removed from participating in decision-making structures, governments. Our institutions have been built deliberately to exclude and to marginalize Indigenous peoples and their worldviews. And we see that in public health, which has been built on white knowledge systems that excludes Indigenous people from mainstream health initiatives and education. So one of my first observations in the program was the holding up of white epidemiologists and white public health professionals, even in the fields of Indigenous health and in global health. So you'll see John Snow here Not the Jon Snow I love from Game of Thrones, but the deemed father of epidemiology because of his groundbreaking work to trace the source of a cholera outbreak in London to a particular public water pump. And I actually did a little bit of an exercise yesterday where I went through my epidemiology textbook to show how whiteness is normalized in mainstream public health. And I took every picture of a person, and that slide here is showing all those, and I was like, every single person in the textbook was white. We have Jon Snow, Edward Jenner, an English physician who created the smallpox vaccine, Donald Henderson, who directed World Health Organization's smallpox eradication program, and even the cartoons were all white people. You know, all the cartoons showing different phenomena in public health or research methodology was all white people. And I also wondered if race and ethnicity were mentioned in the book and at all. And it was actually not until the very last section on page 373 in the 377 page book. In instances where Indigenous people were talked about, it was non-Indigenous people talking about us and our health. And Jorden is going to walk us through the racist ideologies and colonial narratives that are perpetuated in public health when it is non-Indigenous people talking about Indigenous health.
Thanks, Eryn. And so why is it that Indigenous people were left out of this narrative? And well, the easy answer to that is colonization. However, even in today's day and age, we often aren't even naming colonization as the real risk factor. And that's an observation we notice is commonplace in public health. So looking at the graph on the left, it's comparing life expectancy at birth of First Nations people versus all other people. And just before I get into it, this is an example that Dr. Danielle Bain-Smith shared with me and is like really instilled in me. And so I love sharing it every opportunity I get. So even though the print on this graph is small, I bet every person knows instinctively which line is which. And it's because we've normalized this very unnatural phenomenon of worse health outcomes for Indigenous people. And it's so easy to participate in this normalization when we misname the risk factor. We say things like First Nations people have shorter life expectancy than other people in BC. However, Indigenous identity is not a risk factor. We are not inherently more unhealthy because we're Indigenous. Indigeneity is something that actually provides wellness to us. It's a wellness factor. Being Indigenous is a source of strength, and it's our culture that keeps us healthy. And so it's actually colonization that is the risk factor. And a more truthful way of sharing this data would be being subject to colonial policies and practices is associated with a shorter life expectancy. So you can see that we really changed the framing from Indigenous identity to colonization being the real determinant of health. And when we change this framing, it becomes so clear that it's not the responsibility of Indigenous people to do something differently, but instead it's the responsibility of our settler institutions to do something differently. Non-Indigenous people are the ones needing to change their behavior.
Yeah, and I just while you're plugging that in, I see a comment in the chat saying, why can't we say that First Nations people are dying sooner? And it's something that we can say because it highlights, you know, that unnatural phenomenon, and as we should be highlighting the inequities that are happening. But what we'll talk about more is how we frame that, right? So why are First Nations people dying sooner? And Jorden's framing it in the context of colonization so that we can actually figure out where the problem lies so that we know it's not the problem with First Nations people, but it's actually the problems to do with colonization that creates those conditions for First Nations people to die sooner.
Absolutely. That's exactly what I was going to say, Eryn, is that when you were giving these types of statistics or these phrases, if you were not setting it within the root problem of racism, settler colonialism, white supremacy, then the problem is still lying with First Nations people and not within the systems and institutions that are causing it. Hopefully that makes sense. And so this narrative that we're talking about is also used in textbooks to educate healthcare workers, public health students. And so Indigenous ancestry is named as a social determinant of health. And that is wrong. Again, being Indigenous does not make you likely to be more unhealthy. It is being subject to these colonial policies and practices. And this is why we see stereotypes perpetuated as if there's something inherently wrong with Indigenous people. This harmful narrative is also consistently used in the media, and I really encourage you to question every headline you see about Indigenous people. Both of these headlines focus on First Nations people as if they're a risk factor and they're the problem here. So we need to rethink where the problem lies. And likely a more truthful way of sharing this is that First Nations people are being forced into a health system that was not built for them and is not working for them. And Eryn's going to share another example of ways we see this in papers throughout public health and academia.
Yeah, absolutely. And part of the problem too is that it's non-Indigenous people talking about the health of Indigenous people without that proper context, right? So that's another important piece, is who's talking about this. I was so astounded at the amount of papers out there by non-Indigenous people talking about the poor health of Indigenous people through that deficit-based lens, and no mention of the root cause of colonization. So here's an epidemiological study that is perpetuating those same narratives that Jordan just showed from the media. This one is looking at the epidemiology of diabetes between First Nations and non-First Nations adults in Saskatchewan. In this case, the exposure or the risk factor that they're looking at is being First Nations, and the outcome is diabetes. And the finding was that being a First Nations woman makes you 4 times more likely to have diabetes than a non-First Nations woman. And being a First Nations man makes you 2.5 times more likely to have diabetes than a non-First Nations man. So they're saying that it's an ethnicity-based pattern, maybe related to the genetics of energy balance, maybe related to environmental factors. But what is missing from this is that context, that being subject to colonialism impacts virtually all socioeconomic factors, which then in turn impacts health outcomes. It creates the conditions for poverty, isolation, poor access to healthcare, food insecurity, obesity, all of which plays a role in the development of chronic conditions such as diabetes. And on top of that, First Nations people have been removed from their lands and prevented from accessing traditional food gathering activities and practices that promoted all aspects of health.
And it is definitely worth reiterating again that being subject to Canadian colonial practices and policies is bad for Indigenous people's health. And it's the imposition of these colonial policies onto Indigenous people, which violates their right to health, their right to wellness, their right to live discrimination-free. And so sometimes can maybe be hard to see how a potential simple policy can have such a large effect on the health of Indigenous people. And so this book actually does a really great job of expanding on this idea. 100% suggest reading it if you've not had the opportunity to yet. It's called White Benevolence, Racism, and oh, you have it right beside you, of course, Eryn. Oh, wait. Me too. Racism and colonial violence in the helping professions. It's an amazing resource for understanding how colonial ideologies persist today. So one example they provide is colonial scripts, and it refers to the narratives, practices, institutional norms that have been shaped by colonial histories and ideologies. And these scripts have been deliberately imposed. That's the important part to remember. And they're embedded in our societal structures. And they are things that keep settlers, colonizers in power. So these scripts include deficit framing, viewing Indigenous people as always struggling and needing help. And so then white settlers can come in and help, resulting in this savior complex, believing that they know what's best and they can be the ones to fix Indigenous peoples. Colonial scripts are also a tool for assimilation efforts, trying to get Indigenous people to buy into the Western worldview. And so later on in this presentation, we're going to be kind of presenting some alternatives to this framing. But it's important to recognize that in public health, specifically epidemiology, it really perpetuates the colonial script through the negative statistics that we see. especially when the negative statistics don't speak to colonization being the root cause of these stats we're seeing, and thus serving to further the colonial agenda.
Yeah, and I just wanted to add on quickly, Jordan, about how these colonial scripts relate directly back to land dispossession, right? So for the purpose of settler colonization, to build the colonial nation, to remove First Peoples from their land was not sufficient in itself. Colonization also had to be justified, and it was justified through the imposed beliefs that First Peoples are not only inferior, but are actually less than human. And this notion stems all the way back to the 1400s, the 1500s, which shows that these colonial scripts have been functioning for hundreds of years and are so embedded within our institutions in the settler state of Canada. And we see those colonial scripts embedded within the healthcare system as well. Our healthcare system was built on ideologies that First Nations people were less than human, and this deeply embedded racism and discrimination results in negative impacts to health outcomes. This figure comes from the In Plain Sight report, and it shows how the colonial narratives, the colonial scripts that Jordan was talking about, negatively impacts health outcomes in healthcare. So it starts with that intentional creation of systems of oppression, the intentional cultivation of beliefs that Indigenous people are less than, as well as the creation of a healthcare system built upon racial segregation and discrimination. These intentional cultivated beliefs and the stereotypes creates internal prejudice that then gets acted upon, leads to discrimination, lowers access to healthcare, affecting health outcomes in an ongoing cycle. And this cycle can be broken by upholding the Indigenous rights to health through self-determination and Indigenous leadership, cultural safety and humility, and anti-racism. So the work that I do at PHSA with PHSA Indigenous Health is to break this cycle, to embed anti-racism and Indigenous rights throughout the healthcare system so that Indigenous people can access care that is safe and free of racism and discrimination.
And so to break the negative health impact loop that Eryn shared, we really need to be focusing on systems of inequality and looking not only at those who experience racism, but also those who perpetuate it. And so the best way I've seen this explained is through Dr. Stephanie Nixon's coin model of privilege. And I'm going to share kind of the broad idea of this. The coin is to translate core ideas about anti-oppression, anti-racism to people in positions of unearned advantage, aka people in positions of privilege. And so the coin itself represents social structures that produce and maintain inequalities like sexism, racism, ableism. So groups who are disadvantaged by social structures are viewed as being at the bottom of the coin, the oppressed group. And common names we give to this group are marginalized populations, disadvantaged groups, vulnerable communities, high-risk groups. And Nixon provides a really great quote in the article. Unfair disadvantage associated with the bottom of the coin is usually in plain view. It's these groups who have historically led movements to dismantle the coins, such as Indigenous people leading movements to address the harmful effects of colonization. And so the other group of people who receive advantage from these very same social structures are viewed as being at the top of the coin. And this groups receive benefits from structures which they did not earn. They receive these benefits because they just luck into being in alignment with the norms of that particular social structure. And this group doesn't actually have a commonly referred to name. We often hear this group being called like normal or average persons. And so unearned advantage associated with being at the top of the coin is often invisible. The obliviousness of people in their positions of privilege is a key strategy required to sustain the systems of inequality. Indigenous physician and public health leader, Dr. Marcia Anderson, really frames the issue of like where the problem lies in a great way through this quote. From now on, instead of vulnerable people, I'm going to use the phrase people we oppress through policy choices and discourses of racial inferiority. It's a bit longer, but I think it'll help us focus on where the problem actually lies. And so again, looking at the coin, the goal is not to move people from the bottom of the coin to the top because both positions are unfair. The goal is actually to dismantle the system, dismantle the coin, causing these inequities. And it's so important to understand that we cannot only focus on the bottom of the coin, which I think historically is what people have done. They've looked at Indigenous people and said, how can we fix them? But we actually need to shift where we see the problem. It requires those at the top of the coin to recognize that they are complicit within the system of inequality as well. So working towards dismantling inequity really requires different actions depending on your position in relation to that inequity. So this means depending on the inequity you're looking at, you may be on the privileged side of some coins, and for others, you might be on the oppressed side. So I am an able-bodied, straight, cis, however, I'm also an Indigenous female. And so recognizing our complacency in relation to our positions on the coin is key.
So we're going to talk about a specific system, so a specific coin, and that is whiteness and white supremacy. But before getting any further, I want to acknowledge that white supremacy is a very heavy word, and it sounds radical, and it might be making many of us uncomfortable, particularly the white people who are listening in right now. But also, this is a normal reaction, and I just invite everyone to challenge themselves and to lean into that. And we're going to talk about white supremacy as, you know, as a fact, as a system that impacts all of us, not necessarily specific people who are white supremacists, but we're going to talk about it as a fact. So whiteness is not just being a white person, but it's actually a system that allows white people to dominate in society, to remain in power. So our healthcare system has been built by white people with Eurocentric knowledge to purposefully exclude and to marginalize Indigenous people. And because of that, there is deeply embedded ideologies of white supremacy and racism that continues to confer unearned advantage to white people and unearned disadvantage to Indigenous people, and also Black people and people of color as well. So think about the highest level of decision-making power in your organization or your non-Indigenous organization anyways. Governments, health authorities, nonprofits, whatever it is. So my organization, for example, PHSA, although we are very committed to equity and anti-racism, yes, but the highest level decision makers are white. And this is normalized by the system of whiteness. We also know that no one here listening in created this system. We are not blaming anyone listening in for creating this system, but we are recognizing it and we are intentionally bringing it to light so that we can actually work to dismantle it. Each of us has a relationship with that coin. You know, I am a First Nations person that has been socialized in a white society. I'm harmed by white supremacy, but I also uphold white supremacy in some ways and have a responsibility to work against that myself. If we are to dismantle this coin, we must first be comfortable to talk about it. And if not comfortable, being okay with being uncomfortable and leaning into that. So yeah, as long as we shy away from talking about it, then we're never going to address it. So how do we begin to address it? Well, knowing that whiteness functions at individual, institutional, and systemic levels, how do we work against it in a way that is so entrenched in the system? And so thankful to my colleagues Nancy and Alicia, who have told us what we need to do to address it. And first of all, it takes a lot of unlearning. So, you know, we have been born into a white society. We have been socialized. It is so deeply ingrained in us. I know it's so deeply ingrained into me. So in addition to learning, there's a lot of unlearning that comes along with that as well. We need to uphold community-driven action by meaningfully partnering with Indigenous communities and actually following their direction and being accountable to them. Something that I see come up a lot of the time is that when Indigenous people are partnered with, if there's any challenge to the status quo by that Indigenous person or that community member, usually or very often the white organization will shy away oh, no, I don't want to do that, right? So it's being okay to be uncomfortable, being okay to be challenged, and stepping into that space. We need to use our voices to influence decision-making within our organization and our disciplines. I know that, not all of us are the top level of decision makers, right? But it's about what's finding within your sphere of action. What can you actually do yourself, and what's in your sphere of influence, which is a lot bigger than your sphere of action. Maybe you don't have a direct hand in that, but you have a voice to influence, to speak up, to influence how decisions are being made. And we also need to take the time to learn and to understand policy tools that are available to leverage, such as the United Nations Declaration on the Rights of Indigenous People.
Thanks, Eryn. I'm just waiting for a sec because I forgot to put up the last one right away, letting people have a second to read it. So now we're going to be talking about shifting the power of whiteness. And so people in positions of privilege, they often carry the power that's needed to dismantle systems of inequality. However, just because one holds the power does not mean they are the experts. And so often people in positions of power are like, oh yeah, of course I want to help Indigenous people. I want to help those who are not doing as well as I am. I want to use my expertise to reduce inequalities for Indigenous people. And they usually say these things without recognizing that they're actually trying to change Indigenous people to fit into a system that was created by Europeans or white people, and not into a system that really works for Indigenous people. And so we really need to be shifting the power of whiteness to recognize our privilege and our beliefs. And so we need to seek to understand our own role in upholding these systems of oppression. We want to learn from the expertise of and work in solidarity with Indigenous people. And so to put it like very bluntly, working towards eliminating Indigenous-specific racism does not require white people to come in and save the day. It requires white people to stop upholding the systems of whiteness. A way I like to explain this is often in our organizations, we are required to take a cultural safety training. However, and sometimes people see that as being the check mark for being able to go and engage with Indigenous people. You must understand where you come from, who you are, your own positionality before you get to talk or do anything with Indigenous people. You can't have a safe consultation with them if you don't understand who you are in your position. And so really understanding your own role first is the necessary first step before you step into any consultation. Before you get to learn about Indigenous culture, you got to work on yourself first. And that also is for Indigenous people as well. I'm still trying to understand my relationship to whiteness, the way I uphold different systems, because like I said earlier, we are all so seeped into these whiteness systems and these colonized systems. It's often all we've ever known. So one of my favorite quotes is from Lila Watson. If you have come here to help me, you're wasting your time. But if you come because your liberation is bound up with mine, then let us work together. And I'm often reminded that we will not find liberation within the system. We will only find it within each other because we each individually make up the system.
Yeah, thanks, Jordan. I just wanted to talk a little bit more about that imperative to save or to help. And I want to acknowledge that, to grapple with the fact that you or we might be causing harm just in our day-to-day can be unsettling and uncomfortable. I know many of us on this call are probably in the helping professions, in the health realm, or in social services, and we go into that field because we are good people and we want to help and we want to do good. So the idea that by going to work and doing our good work and, doing what we do day to day could be causing harm is probably unsettling or can be unsettling to some folks. And it's those colonial scripts that Jordan was talking about that allow people in the helping profession to assume innocence, right? Because when you're working with people who seem inferior, well, it is good that I want to help, right? I'm helping people who can't help themselves. So even if we are good people, many of us are motivated by that patronizing imperative to save Indigenous people. And I know I'm generalizing here, but I think it's a subconscious ideology that many people hold without even realizing it. And it's not just at the individual level, it's at the systemic level, right? How have systems been designed to save or help Indigenous people when really they were designed in the first place to assimilate Indigenous people? And those legacies are still entrenched in those systems and the impact people and how people show up. So just really encouraging white people on this call to begin to grapple with that and address that. And me as an Indigenous person, I know that I need to grapple with that and address that as well. So also knowing that I have a role to play in that and dismantling that as well. So now what we want to leave you with some examples of how our organizations are picking up the anti-racism work in a good way. And I'm going to start off by talking about PHSA and the work that we're doing. So I previously talked about our worldview in society and in public health more specifically, and how this and now I'll share that this can also be understood as the operating system. We have really, really advanced technology. We've got the brightest and the fanciest new iPhones. This actually isn't an iPhone, it's a Google phone, but I feel like most people have iPhones. So maybe you can relate more to that. We have the fanciest, most advanced iPhones. But as long as the operating system is out of date, it's not going to work. The apps are going to crash. And within the healthcare system, we see that the operating system is out of date in that it is based on white ways of knowing and doing only. And because of that, it's not going to work for Indigenous people, and it's not going to work for Black people or people of color. And so we need to update the operating system so that our technology, our fancy tools, our iPhones, our Google phones, our Androids, all this technology will work for everyone. And so we at PHSA are working to update our operating system to one that honors and upholds First Nations ways of knowing and doing and being from the lands that we are operating on. But we also know that the First Nations teachings is the really, really rich work that will only be rich if we do the hard work of anti-racism first and ongoing, which is why anti-racist practices is being woven into the operating system as well. I love this quote by Abigail Echo Hawk. She says that, "Do not come to us because you think we have the most problems. Come to us because we have the answers." Indigenous people have long and rich history in protecting and promoting our health and wellness through holistic practices that nourish our bodies and our minds and our spirits. We have always known that the land and social connection and culture and ceremony, physical activity is good medicine for our entire beings. And we have really rich ways of knowing and doing that have informed the ways that we have always done research, right? So we have the answers. So at PHSA, we have adopted co-Salish teachings that were gifted to us by Musqueam knowledge keeper Salkson. And the co-Salish teachings guide us as we work to build a culturally safe and anti-racist environment for Indigenous people accessing our services and for Indigenous people who work at the organization. They provide another way to solve problems and address challenges together that white ways of knowing and doing cannot. And I'm getting really excited, so I'm a little out of breath. So I'm gonna pause and take a breath, and I'm going to talk about the co-Salish teachings. So Salkson teaches us first and foremost to be grounded in the eat, the truth of the real history of these lands and our accountabilities to BC First Nations on whose lands we operate on. So when we talk about the eat in public health, what's the history of public health? What's the real history of public health on these lands? What is the truth about how public health has caused harm and is causing harm? The second, Aislachen, means good medicine. And we as humans, when we wake up every morning, we set our intentions to be good medicine to all living things. I think about what we talked about today and the work to shift that focus away from Indigenous people being sick, and how that's part of our responsibility to be good medicine to the First Peoples on whose lands that our systems operate on. Natsamat, we are one, to treat all living things, including the water, the plants, the land, with respect, because we are all connected. Right? Natsamat, we are all connected. We are all related. And I think about, one of the pieces in public health and in disease transmission being that the health of one person will impact the health of another person, to impact the health of another person. And that's something that First Nations people have always known. The health of the land connects to the health of the people and vice versa, and the health of each other impacts the health of others in our communities as well. Wahuks and Squalwin, open your hearts and your minds to new ways of being and doing. I think about how, in this we're presenting new ways of looking at things that might be new to people or uncomfortable. So yeah, having an open heart and an open mind in that. Kwam stan squalwin, make up your minds to be strong, whether you are an Indigenous person working in a harmful system, trying to make it safer for our relatives, or a non-Indigenous person grappling with that relationship to white supremacy. It is hard work and it takes strong minds and strong hearts. And finally, teameth it to do your best. Each person is doing their best, and when that's the case, each person pulls their weight in the collective canoe journey that we're on, and doing so inspires others to do their best as well. So these teachings, they come from the land with tens of thousands of years of knowledge and practice, and helps us open our hearts and our mind to new ways of being and doing that everyone can benefit from, not just Indigenous people, but everyone as well. And we don't take these lightly. It is such a tremendous, tremendous gift that Salkson has gifted these to the organization. And, I really reinforce that whenever I talk about the Coast Salish teachings, is just that gift, knowing that there are, Musqueam children and adults who have never had the opportunity to learn these teachings, and yet they're being gifted to us at PHSA, is just a tremendous, tremendous gift that we have a responsibility to accept with humility and to uphold with humility.
Thanks for sharing that example, Eryn. So I'm going to share some teachings and some work that I was previously doing at the Office of the Provincial Health Officer. And this was part of Dr. Kate Youngblood's postdoc with the Unlearning, Undoing Racism and White Supremacy Project, and with Dr. Danielle Bain-Smith. So often people they have buy-in to this work. They know they want to do anti-racism. They want to focus on eradicating Indigenous-specific racism, but they always have the question of how. Like, okay, I want to do this, but how? What do I do? Where do I look to? What are my first steps? And always I go back to, in order to combat the ideas of white supremacy and racism, we need to be upholding the collective Indigenous voice. Indigenous voices have told us time and time again exactly what we need to do. We need to ensure that our actions and our practices are aligned with these collective voices, in addition to community consultation where necessary. And so these clear directions are laid out in all these reports. I think there's over 1,000 different ones. We have federal reports such as the Truth and Reconciliation. There's 94 calls to action. We have the MMIW, Two-Spirit, LGBTQIA+, calls for justice, UNDRIP action plan. We also have UNDRIP at a provincial level, referred to as DRIPA. We have In Plain Sight that came out in 2020. More recently, we have Remembering Keegan, which is a beautiful case study that was gifted to FNHA and has 23 recommendations specifically for healthcare. So we have these directions. And I'm always reminded that reports specifically like TRC and MMIWG, they came out because of testimonies from thousands of survivors and their families. And so it is our responsibility to respond to these directives and really uphold them. And I do want to say, just kind of like a side note, I used to amplify here how this is evidence that we can't look away from because so many people have told us. However, I had an interesting thought when I was speaking with one of my mentors, Janine Erickson, and she kind of reminded me of the phrase, every child matters. And we started talking about, like, why isn't one story enough? And so why is it that we need to hear the same story from person after person for us to believe that it's legitimate enough to honor and make changes on? And it took me a lot of thinking on how to respond to this, but I think I see it as, these systems, these non-Indigenous systems want very precise and empirical evidence, and they want it on their own time when they're ready to listen to it. And I think that's the reason that we've had to tell our truth so many different times in so many different ways. But so nonetheless, these are directions that now have been given to us and we need to uphold. So in my work with the Provincial Health Office, we realized that many people in our office were not aware of these clear directions. And so we created a Foundational Obligations to Indigenous People series. It was a workshop series that aimed to educate our staff members on all the different instructions provided by Indigenous people. We held it once a month it was a 2-hour workshop. It spanned 4 or 5 months, and we gave people homework to do before, so prep work, and they had to come to the session having read the reports, having chosen an instruction that they felt like they could really respond to in their work. And so in the last session, we held an accountability session. And in that accountability one, we, as a collective team, identified 24 foundational instructions that we felt were most relevant to our responsibilities at the Provincial Health Office. And we use those 24 as a tool to really stay focused for the next year on those ones and upholding those specific instructions. Our hope is that in the future, we can move on to other sets of instructions if we have done our work and use our influence to respond to some of them. But that is an ongoing process. And what I really took away from this work is that these instructions require everyday attention and everyday action. So there's a website for Unlearning and Undoing project, and I usually have a QR code, and I forgot to put it in this presentation, but maybe once we're getting to Q&A, I can find it and put it up because it has a lot of the tools that we started using at the Provincial Health Office to do this work. And so this workshop series, I think there's some information on the website about it, and some of our other tools like the Unlearning Clubs and our rapid colonial not review tool, a little wordy. There's lots of information on there. So I'll try to provide that to you later or even put the link in the chat. So that's mainly all, Eryn, that I have for you, but we did want to leave you off with these final teachings. Dismantling colonial structures requires naming, understanding, and disrupting whiteness, and being okay with being uncomfortable. It requires staying committed to your unlearning journey, really recognizing that racism is an everyday problem that requires everyday attention. It also requires understanding that the root of health inequities is historic and ongoing settler colonialism. It requires expanding your worldview by upholding Indigenous ways of knowing in a really good way. It also requires upholding the legislative commitments and provincial obligations, like I just talked about. And finally, it requires embedding the inherent rights of Indigenous peoples at every point in time in all the work you're doing. The end. Thank you.
The end.
I will stop sharing my screen.
That was amazing. You guys are a powerhouse. Like, just very good energy and very knowledgeable in public health. And I look forward to seeing what you guys do as Indigenous leaders in this industry. And yeah, so we have a few questions. And I will get to the first one. First question is, how do you navigate working against systemic colonialism from a work perspective when the work itself faces so many barriers every day?
Eryn, do you have something?
Yeah, I mean, that's a really good question and just speaks to all of the barriers and the obstacles within the system. I have worked for Indigenous teams and also non-Indigenous teams, and I think what has really helped me be able to do this work is to have a team of Indigenous people and non-Indigenous people who really recognize and know their role in this area to lift each other up and to walk alongside each other. I know for me, a lot of it has come down to figuring out like where can I do this work in the most sustainable way, knowing that there are a lot of teams and areas that are not ready and have a lot of work to be done, and it can be a lot of endless fighting and a lot of work that can be quite exhausting, which really comes back to that support network that we wrap around each other, and really about finding where can I do the best work where I'm supported, and really it comes down again to that network of folks that I have around us. Jorden agrees.
Okay.
I'll let Eryn take that. I'll do other ones.
Okay, that's great. Our next question is, how can we ensure that First Peoples are the ones who write about First Peoples?
Yeah, I think we need more of us in either academia in these positions where we're able to. That is such a good one, but I think there's slowly starting to be systems in place for when non-Indigenous people are putting forward applications, say, to Canadian Institute for Health Research. CHR is really questioning, is this non-Indigenous person the correct person to be leading this Indigenous focus work? And so that is a good step. We're having that question there. But if we have no Indigenous people to come in and do this work, then that's kind of where the issue lies. And so that really starts from like so much earlier on. And that's why we have seats specific for Indigenous students in certain programs. And I know that's such a contentious topic for some people, but the more students we have come through, say, a Master's of Public Health, the more Indigenous people are going to have the tools and the training to come in and do the research themselves in a good way. They'll have connections to their community, even communities being able to do the research themselves and giving them an opportunity to get funding for themselves and not having to go through an academic like university to partner with someone to get funding. So there's a lot of steps, but I hope that we are on a path there.
Yeah, I just wanted to add on. I know we talked a lot today about the harms with non-Indigenous people, talking about our health in the mainstream system. But what we haven't necessarily highlighted was just the amount of Indigenous people who are reclaiming their stories and are reclaiming their health. And that is also happening. However, it's the mainstream system that is not recognizing that to the degree that it should be. But there are so many communities and peoples and organizations and networks and research groups who are doing that work to reclaim health and wellness and storytelling. Yeah. And so, if you're a student or, whoever you are, just being aware of like which stories that you're looking at, right? So when I want to go and look at, I don't know, maybe the impacts of something on Indigenous people, I'm going to be really clear in terms of where I look. I'm going to look to Indigenous authors who have talked about that, not non-Indigenous authors who have talked about that.
Thank you. Our next question is quite long. So this person said, since the problem isn't First Nations people experiencing racism, but care providers exhibiting racism, how do we shift data collection to focus on the provider and not the recipient of unsafe care? Isn't that the only way to target the source of the issue, to locate the hotspots of culturally unsafe and racist cultures in the clinical settings?
Yeah, so I think it's not a either or. We absolutely still need to be understanding the ways in which Indigenous people are experiencing racism, but we also need to be looking at those who perpetuate it. the only way I can think to explain this is the research that I'm planning on doing through my PhD, where we are trying to find indicators to understand how people in BC experience racism. So that is still a very important point, but we can't be doing that in silo without also. And so the other part of my PhD work is going to be looking to public health leaders and actually understanding their readiness and their ability to lead in this anti-racism sphere. And so we have this tool and we call it the Unlearning Club. And so we try to implement that anywhere and everywhere we can, but it's essentially this sustained unlearning journey that people can take to really understand their own positionality, to really understand ways that they may be perpetuating racism or white supremacy. And having that sustained journey is so important. One thing I'm going to try to implement in this research is using a white fragility scale to understand how it changes over time, your relationship to whiteness and white fragility, just so leaders are also aware when they're coming into this work. Like being like conscious of your position, I think is the most important. And you said it very well in your question, like how can we like understand, how can we collect data for people who are racist? And I don't know if we can. And I think it's about slowly infiltrating these different systems and allowing that unlearning to happen. But also, you really need people to want to buy into this work. You can't just go in and force them because they will not change. I think we're slowly creating this rippled out system where it's no longer optional and people are kind of recognizing that. And that is really also starting because we have such enabling leadership in these systems. Like we have Joe Gallagher as a VP of Indigenous Health. We have people, Indigenous people who are in these really like high up positions of power. And so it's slowly becoming not optional, but great question.
Thank you. Our next question is, when you say health system that is not built for Indigenous people, can you talk more about what a system could look like that would be more conducive to cultural safety?
I was waiting for you to unmute, Eryn.
Waiting for you. Yeah, I think it comes down to community like specific and community determined, like self-determined health and wellness services. However, at the same time, knowing that the mainstream healthcare system, is always going to be there, it comes down to making that system anti-racist as well, right? Because that's going to function, for a while anyways, like that mainstream system is going to be the dominant healthcare system, even in the case where you have community-led health and social services. And so the attention for people working in those services are to make those services culturally safe and anti-racist. And there's a lot of work that needs to be done in that area. Absolutely. I don't know if that answers the question, but hopefully a little bit.
I think it does. Next question is, could you share the information about the Unlearning project? And this person thinks it could be a cool tool for other workplaces within a colonial system. They've said that it's uncomfortable for Indigenous people to learn alongside non-Indigenous colleagues in the workplace. Or is this Unlearning project only for non-Indigenous people?
On mute. Yes, we can absolutely, I can share all the details. I will, when Erin's talking next, I'll try to go find the website link. Definitely for everybody. I think, like I said before, even Indigenous people are on this unlearning journey as well. I can't really remember what else. Sorry, what else was in the question?
Sorry.
Is it down somewhere?
Yes,
okay.
I think we just shared it now.
Yeah. Oh, okay. A good point I have about like it's uncomfortable for Indigenous people to learn alongside non-Indigenous people. So when we do the unlearning clubs, the monthly ones, oh, thank you so much, Rihanna, for adding the website link. Much appreciated. But we actually take an approach of having different cohorts of the unlearning club, and we put people into affinity groups. So we will have a group just for Indigenous people, if there's enough Indigenous people. For usually there's like groups of 5 to 6 to 7 people. We will have an unlearning group just for white people, and then one for people of color. And we do that very intentionally to allow generally white people to really unpack their emotions, not in front of Indigenous and people of color. So they can like kind of go, because there's a lot of people experience so many emotions, anger, frustration, guilt, when they start to talk about these things. And so it's not, in my mind, healthy place to do that in front of Indigenous people. And it's also trying to create a safe space for white people to feel those emotions and process them.
Thank you. Our next question is, do you think public and population health is heading as it relates to dismantling colonial barriers and racism? What, if anything, gives you hope and or keeps you motivated in this work? And where might you still have challenges and barriers in this area?
Yeah, I mean, I think that there are some really good. There are some great teams and organizations who are doing really great work. And I can think about Indigenous teams and non-Indigenous teams as well, right? I mean, I think about the incredible work that the Office of the Provincial Health Officer has done in dismantling colonial barriers and racism. I worked at the OPHO for a few months a little while ago, and it was so refreshing to see a team of mostly non-Indigenous people picking up this work and really getting to like the root of the issue, and not just talking about it, but also beginning to like dismantle the structures as well, just like one day at a time. So we see some really good examples. I know that the BC CDC, for example, has an unlearning and undoing team now too, where they're putting their heads together and they're figuring out how to untie colonial knots at the CDC. There are Indigenous teams as well. Like there's the Chimamuk team at BC CDC who are doing really great work for Indigenous communities. And so there's definitely a lot of really good work out there. And I think, yeah, challenges and barriers in the area. I mean, I think it goes back to me to education and the curriculum too, that's taught to public health leaders and emerging public health leaders, and more need for that anti-racism and that cultural safety training so that those who are entering the workforce have that foundational knowledge as they're beginning their journeys. And that's one example, but Jorden, do you have anything else to add?
Yeah, first of all, thanks, Seamus, for the question and for joining me. I think we are at such a great place for this work. Like, I think there is a lot of buy-in and people don't know where to start. And so having and creating spaces and having education available to people is so important. That is sustained and ongoing. Where was my mind going with this? I had a story I wanted to share. Oh, one thing that really gives me hope is the enabling leadership I see. And I've really noticed that as whether there's a barrier to doing this work. If there is enabling leadership in an organization, people who want this work to be done, it can and will be done. And that's also the barrier I see for some people where they are not getting buy-in in their organization. And it's because the leadership, the people at the top are not the ones trying and pushing for this work to happen. And so it's not happening. And I don't have a solution for that, but that's just like kind of the patterns I have noticed. But we are moving in such a good direction. Oh, and one thing I did want to share is I know we're moving in a good direction because I really like doing this work. Like I don't feel yes, I am still young and I haven't been doing it that long. And obviously I have privileges of being white passing, so it doesn't affect me in the same way it does others. But I feel good doing this work because there are so many people who are interested in it and really have buy-in to it. I did this presentation a few weeks ago, and one thing people kept saying is like, thank you for allowing me to feel confident in talking about whiteness. And I was like, oh, interesting. I've never thought twice about talking about whiteness because ever since I started my career, it's just been normal. And so I think even that is such growth that I can come in and feel so confident understanding the root causes, the system, the way it's working. And so we're growing. And then people who are going to be behind Eryn and I are coming up, like they're going to be already have this amazing worldview and they're going to come in and change these systems. So we're on a really good path.
Yes, you guys are. Our next question is, how do we bring this to our leaders, including those in Congress, who, when a lot of them are older and are unfaltering in their beliefs?
I don't have a good response for this. I just feel like you can't change the minds of those who don't want their minds changed. I think you can provide the information as many times as you want, but it's going to be up to them to pick up those teachings. And sometimes that requires them to hear the message 10 times, 20 times, maybe more. It's not very hopeful, but maybe you have something better, Eryn.
No, I think that's one of the main barriers too, is that there are people who are in decision making or who have that decision making power who don't have that enabling leadership like Jorden was sharing, and who are quite resistant to the work. And so I think part of it is planning for when resistance will show up, right? We know that resistance is going to show up. It's inevitable, right? And so is there a type of plan in place to do this? So that to do this work so that the work doesn't stall when you reach that resistance. And I don't know if I have actual specific examples of how to do that. Other than I agree, it's frustrating and the resistance is there. But I think, part of it is that, like Jorden was sharing, like this is an obligation now, right? Maybe use the accountability tools, right? The Declaration on the Rights of Indigenous Peoples Act says we have to do this. We got our mandate from the government saying that we have to do Indigenous-specific anti-racism work, right? And so wherever leaning on those accountability tools can be one way to get around that. But that said, it's not easy, especially as like a young person who doesn't have that same amount of power in an organization.
Yeah, I think also maybe if the top person doesn't have buy into this work, but finding those around you who do and like creating that cohort of people who are trying to do that change, eventually they will have to buy into this work if everyone else around them is. Someone who is amazing at changing the hearts and minds of people is Joe Gallagher. Eryn works for him and I'm sure has seen it many times, but he is somehow able to convince people of any of these messages. And I really, really respect and look up to all of the work he does.
Yeah, I agree.
Thank you.
Serene, I know you're reading out the questions. I just wanted to have the opportunity to speak to someone who is providing some really good knowledge and teachings around the terminology, specifically obesity. And I just wanted to read that out because I think it's a good learning opportunity for me and for everyone. So someone is sharing the really important teaching that the term obesity comes out of enslavement of Black people via the transatlantic slave trade, because their bodies were larger and had greater adiposity, question mark, I might be pronouncing that wrong, than white bodies. And so there is a new FNHA language toolkit that has good language to be using to not perpetuate those terms that are rooted in capitalism and colonialism and patriarchy. So I'm going to put that into the chat, and I'm going to take the time to read that as well. So
That's awesome.
Thank you for sharing.
Yeah, thank you so much.
Thank you. Our next question is, this person really appreciates the information and inquire whether this will be a part of medical school training, as it is direly needed given the colonial perceptions and ingrained ideology towards Indigenous people. They go on to say that there's many healthcare providers immigrating to Canada and getting this training, particularly in the medical field, as the discrimination and racism extends to through the medical practicum, regardless of ethnicity of the service provider. As an Indigenous woman and person, have felt subtly of discrimination by different ethnicities and nationalities from healthcare providers, particularly towards Indigenous people.
Yeah, absolutely. Thank you for sharing that. My heart goes out, and yes and no. So I don't have like all the information and insight about requirements for doctors or in medical school, but they are required to take 2324, which is an Indigenous cultural safety program. And it does get into kind of your position, either as an Indigenous person or as an ally, in your relation to cultural safety. I don't know if it shares these specific messages that Eryn and I shared. We both facilitate for the workshop, so I think we try to like sneak in these messages where we can. But I think there is a larger conversation that's needed beyond just these cultural safety modules in the helping professions that is, once again, ongoing. And I don't think we're at that point yet, but I absolutely see a need and a gap there.
Thank you. Our next question is, so how can work written by Indigenous peoples who have a wealth of knowledge have increased credibility and reach in current white society?
Can you put that question in the chat?
Please, yeah. Eryn, do you want to answer this one, or would you like me to?
Go ahead.
I'm thinking. I think this is a very good question. I'm not sure exactly how to answer it, but
I think it comes up to like general white society, like picking up those teachings, right? And like picking up the books. And I think everyone can like have a role to play in that, whether you're deliberately sharing the works of Indigenous people, right? You're buying them, you're reading them, you're talking about them, and I see each individual having a role to play in actually disseminating that information and to increase the reach in current white society. But I also see a barrier there in that like a lot of mainstream white society might not be picking up the books, but I see that happening. I see people moving towards like recognizing Indigenous brilliance and picking up those books. But I think everyone has a role to play in like, are you buying books by Indigenous authors? Like, are you going to see Indigenous are you going to events, like all those things, like each individual playing a role in that.
my answer, okay, I thought of something. That was such a good answer, and I think speaks more to the question, but something else just popped in my mind that might not be totally relevant for this, but when you're trying to get that buy-in from white people, an approach that was really instilled in me by Danielle Bain-Smith is approaching things with love and care. And it really lowers the defensiveness level of white people when you come with this love and care approach. And that means like recognizing that everyone's at a different place in their learning journey. So when you're coming to talk about these messages that Eryn and I shared, I think like sometimes people have been doing this work for so long and they felt like there's been no shift and they're really angry. And I think when you come in angry, white people sometimes are like immediately shield up and get defensive. And so I have watched Danielle model this approach of love and care, and just people are so much more willing to take in these messages and take in like these actions. And so I really like that approach. I don't know if that exactly answers the question, but it's something I've tried to model.
Great. This will be our last question, just with time and whatnot. We had a bunch of great questions, and I'm sure Eryn and Jorden are happy to share any feedback or anything afterwards if anyone wants to connect with them. But this is our last question. How do you approach public health, which deals so often with physical health measures such as vaccination, understanding many determinants of Indigenous health are so multifaceted and go into other spheres of practice such as education and governance?
Yeah, I mean, I think that really does speak to how big public health is and has the potential to be, even though we only focus on, or we focus mostly on physical health and physical health measures. Health is impacted by so many parts of our life, including education, including governance, including self-determination, which goes into fields that are traditionally considered other fields. But I think it's so important to have that system-wide lens and to recognize all the pieces that impact our health, because health doesn't exist in a vacuum. I think like what much of the healthcare system teaches us, we are so influenced by the land, by our environments, by all those pieces. And so I think wherever we can bring up that systemic level piece and speak to it and bring light to it, I think that that will just like help expand that discourse in public health to that systemic lens that is so important for our health.
Mm-hmm. Yeah, I have nothing more to add. That was
great. I don't know if you guys have any closing remarks, if you want to share any thanks or anything, and then I can close the learning circle.
Just thank you all for being here and listening. We are still in our learning journeys and taking in more every single day. So I feel like I learned so much from you in the chats and the questions, and just very thankful to be here.
Yeah, absolutely. Hi, everyone. Thank you so much for being here with us today. And it was such a great way to spend the morning just learning more and to getting to talk to you and spending time with my BFF Jorden and with Serene and Sin and Kira. So I'm just really grateful for everyone tuning in today. And yes, please reach out with any more questions or opportunities for more discussions. We're open for that.
Yes.
Great. Thank you to all our guests and to everyone for joining us today. Thank you so much, Eryn and Jorden, for the amazing discussion. It was great to hear about your guys' story and how you guys are navigating your journey through public health. It's been very enlightening and inspiring, which is great. And yeah, so just before we end the webinar, we'd love to bring your attention to our upcoming webinars. We have Help Yourself. I don't know how to say that's Help Yourself. That's on March 5th, 10 a.m. to 11:30 a.m. Pacific Standard Time. We have Healing Through Land, Jazz, and History with Delbert Anderson. That's on March 19th. And then we have Indigenous Peoples' Experiences and Realities within the Canadian Healthcare System, what the impact on health outcomes are. That's on March 21st at 10 a.m. 11 to 12 p.m. Pacific Standard Time. And you can sign up for our newsletter. The link will be in the chat. All these webinars are free to sign up for on our website at www.learningscircle.ubc.ca. And thank you, everyone, for joining us today. We look forward to seeing everyone at our next Learning Circle. Lim, thank you.